and Dr. Ahmed Osman, and Tariq Abdel Razik for their invitation, and Dr. Mohammed Shafi as well. I choose this topic, the target therapy in dry eye disease, because since 2018, when we had the JUICE 2, since that we have many new treatments, either physical or medical, and now we don't know how to choose which treatment for which patient. Then, everybody knows what is the definition of dry eye. That is a multifactorial disease with a loss of homeostasis. The word homeostasis is very important because it will be the core of all the treatment and the core of the way of reflection for the treatment. The loss of homeostasis is maybe secondary to a dysfunction of one or more of the structure of the ocular surface. And what is surprising that this estimated worldwide prevalence of dry eye disease ranges from 5 to 50%. The prevalence is very different between populations. And the global prevalence may be influenced by the criteria applied for the diagnosis. And for the epidemiology, we have the worldwide prevalence is from 5 to 50%, and in Europe, it's less than 16%. Then the criteria are different and the prevalence will be different as well. What is very also underestimated and underdiagnosed is the dry eye disease in young patients and in children. It exists. The dry eye disease is not old disease. It's also seen in very young patients and in children. And last year in the in the European Dry Eye Society, we had a session on ocular surface and dry eye in pediatric population. And there is now, with the screens, with the many pathologies, we have more and more dry eye disease in pediatric population. And the prevalence is between 5 to 23% in young. Then it's less than 40 years old, but we need more studies. And I hope that with DEOS, we will do many studies in our area, in North Africa, Middle East, and even part of Asia, because we have really, this is the unmet need in our region. We don't have any real statistics in dry eye disease, either in children, in pediatric or in older population. We all know that dry eye disease may be aqueous or evaporative, and if it's aqueous, we will think about Sjogren. It can be primary or secondary, and all the non-Sjogren syndrome are dry eye, or all the immune diseases. And it can be evaporative dry eye, it can be intrinsic or intrinsic. What are the key mechanisms in dry eye? Everybody knows this vicious circle about Christophe Baudouin from France, and we have instability of the tear film leading to hyperosmolarity. This hyperosmolarity is not good for the ocular surface, that it gives apoptosis and death of cells, and then we will have inflammation. The inflammation will give many cytokines and many markers of the inflammation, and it will increase the instability of the tear film. In this vicious circle of dry eye disease, we have another vicious circle, the vicious circle of meibomian gland dysfunction. And this is really very important if we need to target the therapy of dry eye, because now we have many companies offering many treatments, and nobody knows what is the treatment fitting to which patients. Then we enter in this vicious circle by many ways, and if we are lucky, we know how these patients enter into the vicious circle, and if we broke this vicious circle, we will break all the dry eye disease and all the pathology. Then, if we need to treat it in a modern way, the first thing to do is to remove or treat the triggers. Then we need to know and to diagnose the triggers factors. And then we need to treat the meibomian gland dysfunction, because it's 78% of the dry eye disease And then we need to break this vicious circle to lead off this dry eye. And to break it, we need to break this tear film instability, then to treat the tear film instability, to treat the hyperosmolarity, which is very important, to treat the apoptosis, and for me, the most important thing is to treat the inflammation. Then, how do we treat these trigger factors? We need to remove the preservative, then the bag, to see if you have any environment of dry eye disease like the AC, the contact lenses, the surgery, not to remove the surgery, but to treat the patients around the surgery, whatever the surgery, it will give a loss of homeostasis into the ocular surface. This is the first step in the treatment of the dry eye disease. And then we go back to this vicious circle, and we need to treat every big mechanism. Then to treat, for example, the tear film instability, we have the tear substitute. We can use also the tear retention with the plugs. We can, for the hyperosmolarity now, we have plenty of hypoosmolar eye drops, and if we know that we are in a situation of hyperosmolarity, the use of this hypoosmolar eye drops will treat this part of the disease, and we will restore the homeostasis. The inflammation, we know, the anti-inflammatory drugs, the autologous serum, omega-3 fatty acids, many things. And for me also, because 78 of the dry eye is MGD, then we need to treat the lids and the meibomian glands. If we are back to the anatomy of the tear film, and if we need to target the anatomy, not the vicious circle, if we are in a problem, in a lack of lipid layer, then we need to use the eyelid hygiene is the first line treatment to restore this layer of the tear film. Then dietetic to change the dietetic of the patient, and then the lipid container eye drops. If we are targeting the aqueous layer, in this part we give hyaluronic acid, all the lubricants that we have in the market, and to put plugs just to restore this watery layer. If we are in a situation of the mucus deficiency, and this is the most undiagnosed one, we need to use hyaluronic acid, diquafazole or repamidine, which are mucus secretant, or we have mucus mimetic eye drops now. I will not name one of them, but we have, for example, I don't have any interest, but I can have one of them which is a mucomimetic eye drop. And don't forget to treat the epithelial layer, because this is the part where we have the glycocalyx, and it is this. Thanks to this glycocalyx, the tear film is sticking to the ocular surface. Then, if we have a problem, just look with the drop of fluorescein, if we have something happening into this layer, and we treat it with, for example, PRP, autologous serum, all the matrix therapies, amniotic membrane, or RGTA, or whatever, and the growth factors. Then these are according to the layer. Then what will be the treatment protocol? In the evaporative dry eye, we need to treat the evaporative and the MGD with treating the chalazion, the lid abnormalities, and to treat the inflammation, for example, if you have rosacea. And if in the situation of mucus deficiency, we need to substitute this mucus, and I told you, we have now many of them, many eye drops, mimicking the mucus. And in case of aqueous deficiency, we need to hydrate, or to osmoprotectant, or to retain the tear film. Then for the aqueous deficiency, we have all the lacrimal substitutes. We have in the market now, every company has 2 or 3 lubricants. The punctal plugs are very important in this case when we have, for example, in Sjogren's syndrome, GVHD, all these situations are the situations of lack of water and a lack of secretion, and to re-educate the blinking, and in some cases the IPL therapy may help. For the MGD, we need to treat the inflammation. The eyelid hygiene is the first line treatment. No treatment of MGD without doing any eyelid hygiene. And then we have the heating, the massage, lubricating eye drops, lubrication of the blinking, meibomian gland expression, which is physical, and the IPL therapy. Where is Dr. Asif? Here is the indication of the IPL therapy, but no IPL without eyelid hygiene. We cannot stimulate the meibomian gland without cleaning the orifices to have the excretion of the meibum. If we have no orifices and we stimulate, we can have chalazion, and we can increase the inflammation instead to decrease it. Then we have this vicious circle, that's all we know. The MGD leads to an infection and then inflammation, and we have the Demodex, which is part of this mechanism. What types of treatments? Then we have, as I told you, plenty of them. And if we see back to this vicious circle, if we need to treat the lack of tears, the eye drops are our friends. And if not, we need the eyelid hygiene. And the less costly method is the manual one with a heating mask, eyelid massage, and the eye cleansing. And of course, if you are doing that, after that we can do the IPL therapy. Now, since 2008, it's not a very new concept, but it's now becoming a new concept. It's a new finding in dry eye disease, because when we are treating the inflammation, we are all thinking inflammation, dexamethasone, we are going cyclosporin. But what we don't know that before this inflammation, we have other things. Then the inflammation in dry eye disease is a very, very complex mechanism, as you see. Many mechanisms intricated, many markers, many molecules, but I will let it short. Then, in the case of homeostasis, the ocular surface is postibacterial, and we have these dendritic cells who are responsible of the inflammation. They are quiet, and nothing's happening. This is the case in the situation of homeostasis. What is the lack of homeostasis? When we have an activation of these dendritic cells, we will have a release of markers with the molecules of inflammation, and in this case, we are in case of loss of homeostasis, and this is the starting of the inflammation. And now what we know, that before the inflammation, we have a situation of para-inflammation. And this para-inflammation is well documented. We have many papers and many studies, and this para-inflammation is very important to know in the situation of dry eye disease. The para-inflammation is present in all the situation of inflammation, but especially in dry eye disease. And in this case, the para-inflammation at the beginning, at the early beginning, it's a physiological thing. This is normal that we have a reaction. This is the reaction of the ocular surface to any stimulation, whatever, AC, contact lens wearing, surgery. This is the natural response. And then when we go out of this response, we go to the inflammation. Then the para-inflammation is the situation between the homeostasis and the inflammation. And the inflammation is the disease, the homeostasis is the normal, and in between we have this para-inflammation. And this para-inflammation, we have two situations. The normal one, the functional one, which is physiological, and we have the dysfunctional one, which is the pathological. And with this is the door where we are entering to the inflammation. And in this case, of the functional para-inflammation, we have an endogenous cortisone, because we have the endogenous cortisone, it's released, and this is normal. This is the response of the body to any aggression, or whatever, even the wind. And when we have the release of the markers of inflammation, we are in the situation of a dysfunction, and it's abnormal. And as you see, if the stimulus is repeated, then at the beginning it's normal, and this physiological, and then if we repeat the stimuli, we are going into the way of the pathology. And the homeostasis become loss of homeostasis, and then it become a disease. Then in dry eye disease, we have many papers, and Stefano Barabino is one of the one of the pioneers of this concept. He's Italian, and he's one of the pioneers in ocular surface as well. And he demonstrated that in the situation of para-inflammation, the cortisone, the amount of cortisone in oh, excuse me, I have only 3 minutes. In the tear film is decreasing, and this is the starting of the pathology. Can I have my
The slides, please. ممكن تحطوا السلايدز تاني الشاشة بس.
Then, as you see, we have the cortisone is decreasing. This is why some companies, I was surprised today to see that the company is here. They have now the eye drops, lubricants associated to a small amount of cortisone, of hydrocortisone. This is to treat the para-inflammation. I don't have any financial interest, but I was really surprised to see them, to see the booth here. I will not give the name. You will find them. They have eye drops, lubricants associated to a small amount of cortisone, and this is to treat the early beginning dry eye. As you see, we can go from the functional to the pathology very easily because we don't see the patient and we don't treat him properly at the proper time. It doesn't.
A video? It's a video?
لا.
Can you go? Yes.
Then the exogenous cortisone supplementation can be useful in this case. Then as you see, this is the vicious circle with all the treatment that we have. When we are using IPL, but I will just show you because I told you 78% of dry eye disease is MGD. Then back to the vicious circle, but not of the dry eye disease. This is the vicious circle of the MGD. We have meibomian gland dysfunction. The first line treatment is the eyelid hygiene, whatever you do it. Then the lubricant for the evaporated dry eye, antibiotics for this release of bacteria and the lipases and esterases, anti-inflammatory drugs, and as I told you, hygiene is the first step. Then, now, the IPL, this is why we use the IPL. We use it because it's increased the temperature of the meibum. And like this, we have like heating of the meibomian glands, and we will have a light, and the meibum will be oily, and we can increase the excretion. In the situation of this, we can increase the temperature also with the warm goggles and with, for example, the Lipi Flow, the Ilux, all the ways to increase the heat in the ocular surface and in the lids. And then for the hyperkeratinization, because it is one of the mechanisms, we use the Bleflex, for example, or the new lids when we have the anterior blepharitis, and the new lids is very useful in the first stages when we are only in the situation of blepharitis without MGD. Then you see all what we are doing. What is the mechanism of the IPL? The IPL has 4 mechanisms. The first one, the first one is the neurostimulation of the parasympathetic nerve, which will stimulate the meibomian gland excretion. Then we have an action on the skin, and it was like this that we discovered the IPL and the demotex necrosis, and now it's proved that we have a decrease in neuropathic pain. For example, in a patient with the GVHD, it decreased the pain, and we use the IPL for that. If we are back to the vicious circle, we see these are all the actions of the IPL: the blood vessel obliteration, coagulation of the demodex, photobiomodulation, and influence of the inflammation cascade. This is why for the big inflammation, when we have a lot of inflammation, we can use the IPL because it obliterates all the nerve vessels, and it decreases the release of inflammatory markers. As you see, this is only the action of the IPL. And don't forget, of course, the nutrition, because now we are sure that we have a gut ocular surface axis, and the ocular surface is just, the image what it's happening in our gut. Then please don't forget the nutrition of patients suffering of ocular surface disease. And now I have patients with Sjogren's syndrome. It was very severe, and now because they are doing a proper diet, they are really they are free of all their treatments. Then don't forget that this is a fact now. Don't forget it. And back to the vicious circle, we have a new generation of eye drops of lubricants. We have lubricants with hyaluronate sodium, with the trehalose for the hypoosmolarity, the taurine, it's a hypoosmolar, vitamin B12 for the healing, and the hydrocortisone for the para-inflammation. And all these drops are now available in the market. I don't give the names, but they are available. And if you see your vicious circle, you can choose the proper lubricant, not only the last lubricant that you saw in the meeting, for example. For the anti-inflammatory therapy, we have also plenty of molecules, starting from the dexamethasone, steroids, to tacrolimus, cyclosporin, and cyclosporin in this case, I don't believe only in 1% or 2%, because we need a strong cyclosporin, not the low concentration, maybe tacrolimus, and also the antibiotics, and this is for the bioprotection. This is the new generation of the lubricants, and you see that you have the wetting agents, they are the basis, and then the multiple action tier substitute, and we have the ocular surface modulators like the trehalose, the taurine, the vitamin B12. All of these molecules associated to the lubricants are biomodulators. For the anti-inflammatory drugs, we have, as I told you, steroids, tacrolimus, cyclosporin, one of two, levetiracetam, and we have the antibiotics like azithromycin, doxycycline, erythromycin. All these antibiotics are not used for this antibiotic action. They are used for their anti-inflammatory action and anti-angiogenic action. These are only these classes of antibiotics. You can use them in dry eye disease and especially in MGD, because they have another action, and it's proved that they are anti-inflammatory drugs and anti-angiogenic. And I love this citation by Galileo Galilei. It's not enough to look. You must look with eyes that want to see. They don't want you to see. And this is the escalating therapy according to the DUSE 2. We have now the DUSE 3, and we will announce it in 1 or 2 months, but it will not change a lot. Just keep in mind that the therapy must be escalating. Don't use the big strategies for a small disease. Just go escalating, and please treat before the symptoms, and this is also the escalating therapy according to the stage from 1 to 4 and going without any, don't be iatrogenic, don't do something that we don't need, that the patient don't need. Go with the eyelid hygiene, then the eye drops, lubricants, and then the antibiotics, and at the end we will use the surgery, the cyclosporin, and the tacrolimus. These are, and if you love the ocular surface and refractive surgery, because I know that in Egypt you love refractive surgery, we are welcome to our third meeting of Dry-Eyed Ocular Surface Society. It will be in Bangalore, and it will be from 31 January and the 1st of February 2026. Thank you for attention.
Thank you very much, Dr. Sihem.